And at the outset, I would like to clarify what pregnancy dermatoses are. So it is not just a rash that is occurring simultaneously in pregnancy, but pregnancy itself is the exclusive cause for the rash. In other words, if the patient were not pregnant, she wouldn't be getting a rash. So let's approach the cases. The first case scenario is a 26-year-old female. She is walking into the OPD. She is a preemie and she is in a 36 weeks of twin gestation. And she is having this itchy rash, and it initially started over her abdomen and gradually spread to involve the upper thighs, shoulders, arms. And her lab profile is normal. She is not febrile. So this rules out viral exanthem. And also she is not having any family history of itching. So this again rules out contagious diseases like scabies. So the clues will be she is in a third trimester, she is a preemie with twin gestation, and the rash is initially over the stretch marks. And we can see that there is a profound periumbilical sparring. She is having a normal blood profile and she is afebrile. So this is called PUP. PUP is pruritic urticarial papules and plaques of pregnancy. So why PUP? It's because as the abdomen stretches, the skin produces antibodies against this collagen antigens. So the antigen-antibody reaction, it leads to formation of rash, and that is why we are seeing the rash initially over the stretch mark. So we can otherwise call it the stretch mark rash for easier remembrance. So this is PUP, and we can very well assure the patient that even though she is presenting with a dramatic itch, it is going to resolve after her delivery, and that her baby will not be affected. It will be perfectly normal. So how are we going to treat it? So just symptomatic management will do. Just give her some antihistamines, and if the itching is very much, then we can also give her some steroids. It can be topical steroids like very low potent steroids, and oral steroids can also be given. And at this moment I would also like to tell that we needn't hesitate to give steroids in pregnancy except the first trimester. This is because there is a very light minimal risk, low risk of cleft lip and cleft palate occurring with oral steroids given in first trimester, and that too when the cumulative dose is exceeding 20 mg for more than 2 weeks. So there is totally no harm in giving steroids in this condition, which is especially occurring in her third trimester. So this is the first case. Coming to case scenario 2, she is a 29-year-old female. She is a second gravida in a 33 weeks of gestation, again her third trimester. She is presenting with itchy rash and tense blisters. So here, in addition to rash, the pregnant mother is having blisters, and again it started over her abdomen and it's involving the entire body. It is sparing the mucosa, and lab profile shows eosinophilia. So the clues will be third trimester, rash with blisters and eosinophilia. On doing a biopsy, we noted that there is a cleft between the epidermis and the dermis. And on doing immunofluorescence, we found that there are antibodies produced against hemidesmosomes, and the hemidesmosomes getting affected. So to explain in very simple terms, the skin is made up of cells which are arranged like a brick and cement. So the adjacent bricks are connected to each other by cables called desmosomes, and the lower row of bricks are connected to the floor by connections called hemidesmosomes. So in pregnancy, in this individual, her antibodies are destroying the anchors called hemidesmosomes that are anchoring the lower layer of cells to the basement membrane, that is the floor. So the epidermis is getting detached from the dermis. And you may ask me like, okay, this is just like bullous pemphigoid. So it is occurring in normal population also. So what makes it a pregnancy dermatosis? Yes, the diagnosis is bullous pemphigoid of pregnancy. But why I have included it in pregnancy dermatosis is, the reason why it occurs in pregnancy is very different from why it occurs in the general population. In pregnancy, why bullous pemphigoid occurs is the placenta mimics skin, and the placental antigen has a huge share of paternal antigens. So, in some genetically predisposed individuals, antibodies are produced against the placenta, a cross reactivity happens to the skin, and thus the skin is also getting affected. So, that's why this bullous pemphigoid of pregnancy is included in pregnancy dermatosis. In other words, it is called pemphigoid gestationis since it is occurring in gestation. And again, as we have seen, it is an autoimmune blistering disorder. So, how are we going to manage? Just give the patients immunosuppressants. The safer immunosuppressants will be steroids. So, oral steroids, and for the symptomatic control, we give antihistamines and emollients. And the baby will also present with transient blisters if the mother is presenting very close to her delivery. But we needn't worry because the blisters are due to the passive transfer of maternal antibodies. So, the baby will recover from those blisters in a month or two. So, this is our second case. The third case, a 28-year-old female, again a preemie in 32 weeks of gestation, third trimester. She is having itching all over her body. There is no primary lesion. She is just having excoriation marks from repeated scratching. And in this patient, we are seeing that her lab profile shows an elevated liver function test. So, the clues will be there is no primary lesion in this patient, no rash to start with, no blister to start with. There is only an excoriation mark that is a result of her scratching, and she is having an elevated LFT. So, this diagnosis is intrahepatic cholestasis of pregnancy. Again, why intrahepatic cholestasis of pregnancy? This is because in few genetically predisposed women in the third trimester, as estrogen and progesterone levels are increased, the bile transport is disturbed, and that's why these people land up with ICP. And how are we going to manage it? With ursodeoxycholic acid, and the patient definitely needs a medical line of management. And it's also important to screen for hepatitis C in this patient because if unchecked, she can land up in liver cirrhosis also. And concerning the baby, there is a risk for preterm delivery and stillbirth. So, it's quite important to monitor the progress. So, that's the case scenario 3. Coming to case scenario 4 and the last case scenario. So, this female is a preemie and she is an asthmatic in her 12th week of gestation. Now, this is the only case we are seeing in the first trimester. The other 3 were in the third trimester. And she is having a dry skin, and she is giving a history that she is having itching even before pregnancy, which has aggravated now. And there is a family history of atopy. And on examination, we are seeing that she is having a rash over her elbow flexures and knee flexures. So, this history typically shows that she is an allergic individual. So, the clues will be she is an asthmatic, like all the allergic history is in her family line, and she is also showing the allergic history. So, this diagnosis is atopic eruption of pregnancy. And again, why atopic eruption of pregnancy? It is because in pregnancy itself is an immunosuppressive state, and the Th1 and Th2 balance is altered in pregnancy, and that is why this patient presents with a flare. And there is a tendency for this patient to have this rash with subsequent pregnancies. So, again we are going to manage her with just symptomatic management, antihistamines and so on. So, as a cumulative thing, we are seeing that this pregnancy dermatosis is nothing to be alarmed about, but the timely recognition helps in both reassuring the patient and it helps the physician to be anxiety free. Okay, and just for your thought, as a summary, just see the patient in which trimester she is and classify it as late or early. If she is in an early trimester and is also having an atopic history, it mostly points towards atopic eruption of pregnancy. And if she is in a late trimester having a rash that is mostly over her stretch marks and sparing the periumbilical region, that is PUP. And if she is having an itchy blister along with the rash and you have the positive biopsy finding, then it will be pemphigoid gestationis. If there is a deranged LFT which doesn't occur in any other, then it is intrahepatic cholestasis of pregnancy. And for your thought, you can take this question. A 28-year-old female, a primary asthmatic, 12 weeks of gestation, she is having a history of high fever for the last 2 days. And there is a sudden eruption of multiple itchy tiny blisters all over her body. And she is also having a history of similar episode in her family, that is a child had it 3 weeks back. And can someone guess what it could be? Yeah, you're right. So it's chickenpox, that's varicella. So common things are common. So just because a rash occurs in pregnancy, don't jump into pregnancy dermatosis. It can be something as simple as varicella. Similarly, the other things that a pregnant lady could also have can be scabies. So probe for the family history, nocturnal pruritus history, and she can be using some new products recommended by her peers, like some washes or something. So if she is allergic to those materials, she might get a rash. So it could be contact dermatitis. And again, if she is taking some supplements that are like allergic to hers, she can also land up in drug reaction. So we should also have this at the back of our mind while dealing a pregnant patient. And that's it. Thank you.